Well, I'm somewhat intimidated. It's very difficult to make a presentation after such distinguished presentation made by our guest. I'm going to tell you a modest story about ultrasound diagnosis of the vertebral and subclavian arteries. Well, our nurses don't do this test. And I'm going to elaborate on, again, vertebral and subclavian arteries. What's special here? The standards for studying the magistral cerebral arteries, in addition to like cerebral arteries, includes, again, vertebral and subclavian arteries. What is our armamentarium? We use Doppler US Dopplerography, the most prevalent technique in our country and in St. Petersburg in particular, in all like leading healthcare institutions. And primary care, it's available even in primary care. Plus, we use US angioscanning, duplex or triplex, with the use of various modifications like mapping, B-flow, and frequency shift analysis. And these various diagnostic methods may be interpreted differently by professional. The results of these studies may be interpreted in different manner. That's why I would like to emphasize that what we see depends on how do we look at the scans. Diagnosis of the vertebral arteries in case of ultrasonographic Dopplerography. Well, some people believe that's a screening matter. Nonetheless, it yields an important information on blood flow indicators with the velocity evaluation, with the velocity asymmetry. Up to 50% is acceptable. So we calculate some indices, including the one of peripheral resistance. So we in fact evaluate blood flow in proximal segment, and we have the opportunity to evaluate vertebral and subclavian artery blood flow in a rotational test. Besides, this method allows this technique may be repeated multiple times in order to evaluate blood flow over time after pharmacological and manual interventions. Diagnosis of vertebral artery, again with the use of ultrasonography visual imaging. Now we have the opportunity to evaluate the anatomic and physiological peculiarities of the lumen, vascular lumen, and the vascular wall, all kinds of deformities that may be encountered at any in any segment from the ostium to V4 segment. Plus, you can evaluate blood flow level of the main artery. We can, basilar artery and vertebral artery with the use of rotational tests. So we can follow up patients over time, including follow-up after surgical and endovascular interventions. As of today, so we use national guidelines in the development of which Now, the professors, academicians who attend our meeting took part in, who in fact, again, contributed to the development and approved these guidelines in 2013. As of today, using our guidelines, we again evaluate the ostia of the vertebral areas, and in such a way we describe dystopias. There are some anatomical peculiarities that make imaging of especially left vertebral artery more difficult. So we measure the diameter, understand, and if the artery's diameter is 2 millimeters or less, we believe it's hypoplasia. In terms of diameter of the residual lumen in case of stenosis, those are the national guidelines. So according to which we have to measure the square area. But again, the low diameter of the vertebral arteries and anatomical peculiarities preclude us from using this particular technique. And the ultrasonography doctors use different techniques in order to evaluate, assess the residual lumen. We try to measure diameter. The square area is a more precise, a more accurate method. We do spiral CT, but it's not feasible all the time. And this slide presents atherosclerotic plaque in the shape of membrane. So we basically, not all the times, again, we can do measurements, take measurements. And the major criterion, diagnostic criterion in evaluating vertebral artery, it's actually hemodynamics that would take into consideration again the changes in the lumen and the blood flow distal to the stenosis. And diagnostic criterion is actually 50 to 70% of stenosis, the defect in the lumen and the B staining of the vessel. Registration of the local acceleration and the turbulent blood flow at the stenosis site and over 100 centimeters per second. And what else? So we calculate the index V at V1. And what is significant? Over 2 times. In case of poor imaging of the ostium, or the V1, V2 of the vertebral artery, so we do registration of turbulent blood flow and the blood flow gradient are taken into consideration over 70%. The deformities of the vertebral artery that may be accompanied by various other deformities like loop formation, for instance. The criteria of diagnostic significance are very similar to those used for arteria carotis interna. Again, the turbulent blood flow at the area of deformities, increased velocity over 120 centimeters per second, and significant velocity gradient 2 and more times. Extravasal influences on the vertebral arteries in various segments. V1, so extravasal impact V2 due to spinal problems. V3 and V4 also have like factors that may impact on the blood flow. And again, imaging with the use of Doppler and non-Doppler ultrasonography allow verification of these influences and rule out compression with forming pathological gradient from proximal to distal segment of the vertebral artery. As for the subclavian artery, yeah, we can use both techniques. Doppler scanning be may be an independent method if we want to elucidate on etiology of the disease. It yields information on brachiocephalic trunk and again anatomic variations of the subclavian arteries per se. Even though in ultrasonography, Dopplerography will also pick up hemodynamically significant blood flow changes. What are the criteria? They are as follows. First and foremost, we have to determine the type of blood flow in the magistral blood flow rules out, exclude hemodynamically significant problems. But some conditions may be present even though the hemodynamics is not affected. If we see the collateral blood flow or changes, abnormalities of the magistral blood flow, it's a synonym of the steno occlusion of the subclavian artery. What's significant? Asymmetric pressure, acceptable gradient from 15 to 20 millimeters of mercury. So we have to evaluate blood flow, which is important for the subclavian artery. So we have to evaluate blood flow in basilar artery and the vertebral artery as well. And what else is a part of the diagnostic standard? Mandatory reactive hyperemia test in order to rule out various syndromes of subclavian vertebral stealing. And if indicated, we can perform various vasodilating tests like pharmacological, cold challenge, and mechanical load. That's stenosis of the subclavian artery. That's a hemodynamically significant stenosis with local acceleration of blood flow and with pathological gradient and with the change of shape of this blood flow in the distal stenosis area. And on the right, insignificant stenosis, but with manifestations, with manifestations like changes of the lumen and affected blood flow in the subclavian as well as axillary arteries. That's actually like the syndrome of subclavian vertebral steal syndrome. Less than 60%, intermediate from 60 to 70%, and the highly significant stenosis over 70%. Even though that's not necessary for a certain type of stenosis, we see the subclavian steal syndrome. Everything would depend on blood flow on the contour lateral vessels in the vertebrobasilar circulation, including the blood flow in the carotid arteries. As of today, despite the complex difficulties in ultrasound visual imaging, we can resolve our problems. As of today, doctor, radiologist um, um, may follow the guidelines depending on the technique selected. Also, we have the major criteria of hemodynamic significance, both at early stages as well as over time. Thank you for your attention.